So let's talk about what happens in emergencies. And the emergency world is an interesting world. It's a tough go for you, right? Because this happens to all of you. You see these kind of things. There are two kinds of emergencies. There's BLS emergency and ALS emergency. An ALS emergency is where a lot of providers shoot themselves in the foot and don't get paid what they legitimately could get paid. And the reason they don't get it is the documentation doesn't support it. So all documentation for emergency starts with emergency response. And that means responding immediately to the BLS or ALS-1 level of service to a 911 call or the equivalent. An immediate response is one in which the ambulance supplier begins as quickly as possible to take the steps necessary to respond to the call. What makes something an ALS emergency is tied to the definition of emergency response. An emergency response is necessary in order to get to an ALS-1 emergency. And an ALS-1 emergency is the transport and the supplies and services and either an ALS intervention or the provision of an ALS assessment. That's what I was talking about earlier, the ALS assessment, where you go out and you assess the patient, but you do not perform any ALS intervention. If the definition is met, it becomes an ALS-1 emergency. And the definition for ALS assessment is an advanced life support assessment is part of an emergency response where an ALS crew is needed because the patient's reported condition at the time of dispatch was such that only an ALS crew was qualified to perform the assessment. An ALS assessment does not necessarily result in a determination the patient requires an ALS level of service. So here's what needs to be in the documentation. Number one, we need to know it was an emergency response. Number two, what is it you were dispatched for? You were dispatched ALS for chest pain. That needs to be documented. Number three, that you assessed the patient. Number four, that the assessment was documented. And what is an ALS assessment? It's when you look, I'm paraphrasing, when you look at the patient and you talk to the patient, you, because you were higher trained, are the one who's qualified to decide whether they need you or not. You're the only one who's qualified to know whether they need you or not. Now, let's be real. A good EMT certainly knows when a paramedic is needed. But for the purposes of the black and white of things, for the purposes of the regulations, only a paramedic is qualified to decide if a paramedic is needed. If that's documented, all those pieces are documented, the emergency response, what you were dispatched for, that you assess the patient, then that becomes an ALS-1, even if you decided, I'll drive, you sit in the back with the patient, and no interventions were needed. Because there is a cost to respond, and that didn't used to be recognized by Medicare. It is now. And Medicare set a standard in 2002 where they changed the levels of service. Instead of being dispatched for chest pain and you got there and it was a BLS level issue, you were stuck with it being a BLS level issue. Now they recognize that, hey, we might have sent a NICU. That's a higher level of vehicle. We might have sent paramedics out instead of sending EMTs. And while they're out there, they can't be someplace else. That becomes an ALS-1 emergency. But the important part of this is just because you have ALS does not make it all an ALS-1. So Philadelphia Fire Department has all paramedics. Houston Fire Department has all paramedics. Los Angeles, Seattle, a lot of cities do it. In Seattle, they send a fire truck to every single 911 call, and every firefighter is a paramedic. It's an interesting service model, isn't it? If your operational protocol is that all ALS, or even if you would perform an assessment every single time, that's cool. I want you serving my community that way. That's cool, you can do that. But in order to be reimbursed at the ALS level, it has to meet the definition. And that's why noting those issues like dispatch. So if you do not have a dispatch protocol of what is ALS and BLS, and some smaller services do not do that, now's a good time to go have a chat with your medical director and get it laid out. What we are seeing, however, is a lot of pushback on emergencies. Never used to see this. I only used to see audits in non-emergency situations. Here are 2 cases where the documentation just did not support payment for emergency. And even though it was a 911 call, Medicare wouldn't pay for either of these 2 calls. The first is patient found sitting in a chair, and all the documentation noted is that it was a 911 call, and the patient had edema of the lower extremities. Is that an emergency? My son with his kidney disease has got edema of the lower extremities every day of the week. Sometimes post-dialysis it's better. This could have been an emergency. There could have been something going on there. There just isn't enough information. How about this one? 90-year-old man called 911. He was found seated on the toilet. Patient found blood in the bowl. Is that an emergency? Yeah. Could be. Was this a couple drops of bright red blood? Does this fella have a hemorrhoid? Does this fella, was it dark red, tarry? Is something more serious going on? Are there any other issues? Is he in pain? What are his vitals? All that jazz comes in the whole picture, but that's all that was in the documentation. So the payer said, no, we're not going to pay that. See why it's an issue? Now, there are 2 other levels of service. We have ALS 2. It's a slightly higher level of reimbursement, and it is neither an emergency or non-emergency. It's just ALS 2. And it's transported by ground ambulance and either the administration of 3 meds by IV push or bolus, or it's one of these procedures. By IV push, we mean that it can't be a standard liquid that you use to keep the flow open, okay? It can't be dextrose, normal saline, or Ringer's lactate. It has to be a medication. And it's either one drug given 3 times or 3 separate drugs. So if your normal dose is 6 milligrams and you give 2 and 2 and 2, that's not 3 drugs. That's one drug that you just spread out. But if you give 6, you give 6, and you give 6, then that's three doses of the med. The other thing is automatic slam dunk if it's a manual defibrillation, if it's endotracheal intubation, if you were monitoring any of these things, or you did them, or you attempted to do them. If you attempted to intubate and you could not intubate, you couldn't get access, that still is an ALS 2. And then the last thing is specialty care transport, and I understand in Louisiana you do not have a higher level for your paramedics, but a specialty care transport is a hospital-to-hospital transport of a critically ill or injured patient who needs a level of care beyond the scope of a paramedic. So some states have paramedics trained to a higher level that do this. Other places it might be where a nurse goes along or a respiratory therapist. So those are all the levels of service. And why we have all this focus on reimbursement, we have a lot of focus on fraud. At OIG, Office of Inspector General, there are 2 documents, if anybody wants these documents, that talk about compliance. And the documents are the compliance guidance for ambulance suppliers and the compliance guidance for billing. So if you'd like a copy of them, email me and I'll send them to you. But there's a lot of focus on our industry, and the reason there's a lot of focus on our industry is compared to other aspects of healthcare, we have provided many, many more services. So even though the dollars spent on ambulance are a drop within the drop in the bucket, we have ratcheted up higher than anybody else. When they look at doctors and other people who provide what they call Part B services, which is how ambulance is paid under Medicare, internists are number 1. And then you have radiologists, you have one other provider, the 4th provider on the list who's got more services than any other is ambulance. Family practices and other doctors are underneath ambulance. So that's caused a lot of focus on what we do. In May, these 11 providers in Sacramento were hit with $11.5 million. I have read of field providers going to jail in California for the quality of their documentation. And usually emergency providers don't worry, but here's a rescue squad. You think rescue squad, who would ever have any fraud issues with them? But once they started digging into trip records, I said they usually go back 4 years. This went back 6 years. And they never show up timely. Like, they're going to show up today for something that happened 3 years ago, and then they're going to go back 4 years beyond that. So this fella ended up going to jail. And in my hometown of Philadelphia, we had 2. So this one was charged with $3 million in fraud. Less than a week later, 7 people were charged with $2.5 million in fraud. And the first lady, last December, they sent her to jail for 64 months. And in fact, Philadelphia and Houston are on a moratorium. No new ambulance providers at all in either of these places because we have such a fraud issue. Mostly this is tied up with dialysis. Okay? But you have Novitas, just like I do. Novitas is coming out with a new LCD, a proposed LCD. Go check it out if you've not. They're really tightening what they call medical necessity. Cahaba covers the Carolinas and Georgia. They put ALS-1 emergencies on prepay review. In other words, the bill would be sent to Medicare. Medicare would come back for all ALS-1 emergencies for a while and ask for the trip report. Then when they got around to reading the trip report, and that would not be by people who actually know what a trip report is, then they would decide whether they would pay the claim or not. BLS non-emergencies left and right. And a lot of this comes out of this report that came from the OIG, the Office of Inspector General, at the end of 2013. Released a very thick report about the ambulance industry. It's got lots of charts and graphs, but this is a telling one. Look how much BLS non-emergencies grew. 94%. And so when you say that we had an uptick in services, when you look at other types of providers, nobody else, even though we have an aging population, doctors did not increase their services 94%. Hospitals didn't increase their services 94%. The ambulance industry did. When we look at ALS emergencies, we see an uptick there. That we can explain a little bit more because now we have that ALS assessment rule. We also have a lot of services that didn't used to bill, cities and counties that didn't used to bill, that now will bill or will do insurance-only billing. So it has led to a lot of oversight, including this one from Palmetto. And you were asking about the signatures earlier. Look at what they did. In just one quarter, they denied 6,200 claims for insufficient documentation. Another 3,700 claims were denied for signature issues. No provider signature, no beneficiary signature, or problems with the physician certification. And there is a slide that goes into all of the issues that they had with signatures. On the PCS, it had to do with legibility, but for crews, it was either a missing or illegible crew member signature, and they denied those claims, would not pay them. And beneficiary signatures are another issue. They also went after medical necessity. They found a lot of claims were not documented as being medically necessary, and as they say, it's the responsibility of every provider to maintain compliance and to have full and complete documentation of what happened to that patient. And as I talked to you before, it's not only your substituted memory, but it's how you combat fraud.